I'm so glad to be here and discuss this very important topic.
Absolutely. Thank you so much for joining us today. In the comfort of our own homes, thankfully, thanks to the current situation. We're all at home right now.
Well, makes for fun times to be on webinars and learn, right?
Yeah, there's lots of social media happening right now. So
for sure.
Thank you again for taking time out of your evening and joining us today.
Great.
All right, so we're going to get started to talk about the application process of a surrogate. So I know that, Dr. Sharma, you're not often involved in the very, very beginning stages of building a profile and application, but when you have a new surrogate approaching the clinic, you do review the profile.
For sure.
That is from the agency typically. So what would you typically look for on a surrogate's initial profile?
Great question. And a lot of my recipients also ask me this all the time. They say, what is the ideal surrogate? So typically, in terms of requirements for a surrogate, we certainly want them to have had one normal delivery, whether it be a vaginal delivery or a C-section that was uncomplicated. And the reason for that is, and it might not be so obvious, because I've had surrogates who've never been pregnant before say, oh, I want to be a surrogate. I think the reason for having one successful prior delivery at least is that it shows that a surrogate has been pregnant and gone through pregnancy before without any issues, and they're capable of having a normal pregnancy without, any issues for the intended parents that are going to match with them. So that's one thing, that they've had one or more prior successful deliveries. Two, we look at their health characteristics. So age is an important criteria, mostly because we know that pregnancy complications do increase with age. So while it's not the same as with egg donors where their age affects their egg quality, age of a surrogate is still somewhat associated with pregnancy issues. So typically we say age under 45 with an ideal age under 43, because we know as women get into the mid to late 40s, they have a higher risk of complications in pregnancies like gestational diabetes, high blood pressure in pregnancy, or preeclampsia, higher risk of C-section, higher risk of preterm labor. So ideally age under 45 is good. Another question that we get all the time is body habitus and weight. Now, I can speak for myself, even having had 3 kids, that we all know that once you've had pregnancies and had babies, it's not unusual to gain a little bit of weight. So we're not looking for someone who's like slim like a supermodel. In fact, people who are too skinny are probably not ideal surrogates. We're looking for someone who has a BMI that's, relatively within the normal range, or maybe a little bit on the overweight side is acceptable, but certainly being obese is probably not ideal for having a good pregnancy. So when we talk about weight, we usually talk about weight in relation to height. It's called BMI, and ideally to have a BMI under 30, or equal to 30 is probably best. So we've talked about age, we've talked about having a successful one or more successful pregnancies, we've talked about body weight, how a surrogate did in her prior pregnancies, whether or not she had a normal delivery or a C-section, whether or not it was on time, whether or not there were any complications during the pregnancy also are going to matter, as well as if she has any coexisting current medical problems. And every medical problem is a little different. Let's say if a surrogate has a little bit of hypothyroidism, which is low thyroid, that's something that can be totally manageable in pregnancy. But if they have current diabetes, high blood pressure, and rheumatoid arthritis, that's like too many things. So we do look at their current medical history as well as their psychological history. Any current medications that are potentially toxic in pregnancy, or any toxic habits like smoking, excessive alcohol, or any drug use. That about sums it up.
Yeah, for sure. So if you see something like let's say the surrogate is taking some medications, let's say for anxiety, that's something that's very common these days. Is that something that you would consider for a surrogate to go through?
Yeah. So you're right. Being on anxiety or mild depression medications is so common. I mean, half the infertility population is probably on some element of anxiety or mild depression medications. And a lot of these medications actually are okay in pregnancy, some of the milder ones. So if a surrogate is on a medication that she's been on safely during a prior pregnancy, it's probably okay for a subsequent pregnancy, but we'd certainly like her to check with her doctor. And we always will look up any medications that a surrogate is on to make sure that their pregnancy category is safe. Mind you, it's always best to be on less medication if possible during pregnancy. So oftentimes I'll have any of my infertility patients or surrogates say, oh, you know, I'm on this anxiety medication, but I typically can get off during pregnancy and it's not a problem. And so if they can get off of it, that's ideal. But if they have to be on it, we'd rather have them be on the medication and be able to safely carry a pregnancy than not if the pregnancy can tolerate the medication and it's not considered that high risk.
Okay, awesome. All right, so once you've reviewed the profile, surrogate will typically come to your clinic or the physician's clinic for her screening appointment. So can you walk us through what that screening appointment entails?
Yeah, absolutely. You know, I should start off by saying, like, as a surrogate, you're doing us such an incredible favor and it's such a gift to our intended parents. So our goal is really to make this as enjoyable and rewarding a process as possible. And the medical screening appointment is probably not the most rewarding part. So we want to make it as tolerable as possible. That's our goal. But we, at the same time, want to make sure that all the testing is good so that the surrogate can have a successful pregnancy for the intended parents. So that's what the impetus is behind all the screening tests. That being said, we try to minimize the visits to the clinic as much as possible, whether a surrogate is local or further away, because we know it's time away from work and kids and home requirements and commitments. So we try to make it easier and book everything at once. So when it comes to screening, it's medical screening and psychological screening and laboratory testing. As well as an ultrasound and a sonohystogram. So we try as much as we can to get all of that done in one visit. Typically what the surrogates do is they come in and if possible, they'll do a counseling visit with one of the counselors in person at the clinic. If they can't, we can always arrange that by a Skype consultation, much like we're doing today. They will have a pelvic ultrasound to look at the anatomy because we want to make sure their uterus is normal and there's nothing in their gynecologic anatomy that could be a hindrance to pregnancy. Typically, we'll also try to do the test of the uterus called the sonohystogram, which is a water test of the uterus to make sure the inside of the uterus is hospitable towards pregnancy. We'll try to do that and book it in the beginning of the cycle with their screening appointment. And then they will see one of the doctors or one of our nurse practitioners to get a full history and a physical exam. And that process takes about 30 to 45 minutes where they'll just answer questions about their pregnancy history and their gynecologic history and their partner's history if they have one. And they also undergo blood testing and urine testing, as well as potentially a pap smear and cervical cultures. So that involves a speculum exam, just like a routine gynecologic exam. The whole process probably is about half a day, barring a long wait at the office. But again, we really try to make it one visit to the clinic. And sometimes it's not one visit, it'll be 1 to 2 visits to get everything done.
And so during that appointment, if anything comes up as abnormal, what do you do next? Or even if you could give some examples of what you typically see come up as an
For sure. Yeah, I mean, and I think it's important to note that a lot of things are screened for just by looking at the profile and doing a history on the surrogate, but sometimes unexpected things do come up. I mean, we're human beings, so we're not like robots. So sometimes you do find something. So typically these tests are designed to see if something, you know, is unusual. And so at the screening appointment, sometimes what we'll see on the initial ultrasound is, you know, something that could affect pregnancy but is minor, like a polyp in the uterus or a little bit of scar tissue in the uterus from a surrogate's prior cesarean section. Most of these things are manageable. So if there's something small in the uterus, typically we can book a secondary procedure called a hysteroscopy. It's a small procedure that occurs under sedation where we put a small telescope into the uterus. Typically, it's not the same day as the screening appointment. We have to bring the surrogates back and we can remove the little growth in the uterus, or we can remove the piece of scar tissue. And like I said, most of these things are easily taken care of. Sometimes we'll find a lab abnormality that requires some sort of treatment like low thyroid or some sort of infection that needs treatment with antibiotics. And again, these are things that can be taken care of. Yes, on rare occasions, we'll find something that's not compatible with pregnancy. And of course, that would mean that the surrogate did not pass medical screening. But typically, it's a good thing if we find these things out at the screening appointment before we get way into the process. And it's hard for both the surrogate and the intended parents who have a relationship together. But the majority of things that we find are treatable. And, you know, hopefully most surrogates get cleared once everything's taken care of and we move forward.
Can we look at the thyroid a little bit closer? Because I know that's an issue that comes up often, and a lot of people don't understand the correlation with thyroid and pregnancy. Can you talk about that a little bit?
Yeah, absolutely. I think it's a good question because you're right. It does come up quite a bit. So, you know, in recent years, we've discovered that thyroid hormone, which is produced by a gland in the neck called the thyroid, is very important for your daily life because it controls your metabolic rate and weight and menstrual cyclicity. And it's a very common endocrinologic disorder just in general. But particularly for those women who are trying to conceive, what we found out is that stricter control of the thyroid is really important for reproduction. And by that, I mean, your family doctor could check your thyroid if you're not conceiving and say everything's perfectly fine. But then you come to a fertility clinic to either be a surrogate or you're a fertility patient. And we as reproductive endocrinologists will say, your thyroid's a little off. And I know patients always get confused. They're like, but I had my thyroid checked every year and everything was perfectly fine. The reason we come up with these numbers is that thyroid metabolism in pregnancy is very important. And if you have a slightly abnormal thyroid that might be otherwise considered normal outside of pregnancy, that can affect your pregnancy outcome. And we found that these minor changes in the thyroid can increase the risk of miscarriage and reduce the chances of implantation, let's say after a frozen embryo transfer for a surrogate. So many, many women or potential surrogates who otherwise don't need thyroid hormone outside of pregnancy or doing a frozen embryo transfer need a little bit of thyroid hormone during the surrogacy process and probably need to be on it throughout the whole pregnancy. Typically, once you're done with pregnancy, you can get off the medication.
Good to know. We have a question from Facebook. So Krista said she had a polyp removed before an embryo transfer.
Okay.
And she asked, how common is that?
Oh, it's very, very common to find small polyps in reproductive age women. I would probably say 10 to 15%, if not 20% of female patients who come through my door, whether it's surrogates or otherwise, have polyps. Now, you can live with these polyps if you're not trying to get pregnant, but the worry is if these polyps grow that they're in a uterus and it could impede implantation. And if they're over 1 centimeter, there's some loose association with failed implantation and miscarriage, not to mention the fact that it is pathology and there is a tiny, tiny risk. It could be cancer or something like that. So anytime we find something like this, we want to remove it. So in answer to your question, yes, it's very common, but 99% of polyps are benign, meaning that there's no cancer or anything like that. It's just an effect on implantation. It's a simple procedure to remove them.
Is it a painful procedure to remove it?
So we do it under sedation with this process called a hysteroscopy, and it happens right here in our office. Typically, if a patient is local enough or can come over to do it, and you're sedated with IV sedation, so it is not painful. Sometimes for a surrogate who's further away from our clinic, they'll have to do it with their local gynecologist, but anytime a hysteroscopy is performed, for the most part, it is under sedation, so you don't have to worry about that and pain.
And afterwards, the recovery is pretty fast? No,
quite quick. So we usually say you have to take that day off, the day of the polyp removal, but you do not need to take further days off and the complication risk is minimal.
Great. Okay. All right. So moving on from screening, can you tell us a little bit about the embryo transfer? And first, what is the preparation protocol?
Yeah. So when we talk about doing a frozen embryo transfer, and I should place the caveat that these days, most embryo transfers into surrogates are frozen embryo transfers, just because it's so much easier for the surrogate if we're not sort of coordinating the transfer with the fresh egg retrieval. In addition to that, most of our intended parents are doing genetic testing of the embryos, and this requires freezing of the embryos anyway. So typically they are frozen embryo transfers, just, compared to what we used to do in the past. So there's two types of protocols for the most part, to simplify things. There's two types of protocols for frozen embryo transfer. One is a medicated frozen embryo transfer, and that involves taking hormones, estrogen and progesterone. Estrogen for about 10 to 12 days, up to 2 weeks, to build up the lining of the uterus to get it thick enough for implantation, followed by progesterone, which is in the form of a suppository or a muscular injection into the buttocks. Estrase can be taken in a variety of ways, either orally, vaginally, or as a patch. And then about 2 to 4 weeks, depending on how long you're on the hormones later, the frozen embryo transfer takes place, and then surrogates will remain on the hormones until their pregnancy test. And if the pregnancy test is positive, then they will continue it until 12 weeks. The other method of doing frozen embryo transfers is something called a natural frozen embryo transfer, which I feel like has really come in vogue over probably the last couple of years. And I mean, I myself am a big fan of natural frozen embryo transfers if it's at all possible, because it avoids the hormonal burden on surrogates. The positives are that you don't take any estrogen, really. I mean, you can give it, but you don't need it. And you're just taking progesterone, and the transfer is based on a woman's natural menstrual cycle. The downsides are it requires more monitoring, and you can't alter the day of the embryo transfer. And sometimes it's a little unpredictable, which is not so hot for surrogates who live further away and want to schedule their embryo transfer at a convenient time. But you only take a little bit of progesterone, so it does really decrease the hormonal burden on surrogates. And I tend to favor these types of frozen embryo transfers, especially after you've had a couple of failed transfers with hormones. It's good to just sort of go a little more simpler and remove the hormones, and sometimes you have a better success rate. In speaking about the embryo transfer itself, that is a procedure that's typically not under sedation. It doesn't need to be under sedation. It involves placing a small straw-like catheter with the embryo into the uterus. So what happens is on the designated day of transfer, a surrogate comes into our clinic. They can fly in the day of or the day before if they're from further away. If they're close by, they come in the day of. We ask them to drink water to keep their bladder full to make the transfer easier, because it makes the uterus, which is typically either upright or facing backwards, it makes it straighten out to make the uterus easier to get into. So that's probably the most uncomfortable part, having a full bladder. They're taking it into our operating room and, placed on the bed. And it's kind of like a pap smear. We put a speculum in, we clean off the vagina. I tend to do practice embryo transfers to make sure I can get into the uterine cavity without difficulty. Then we show the picture of the embryo on the screen. Sometimes intended parents come in and they want to be there for the transfer. Sometimes they don't. You get to see the beautiful embryo on the screen with the intended parent's name. We obviously confirm the name of the intended parents as well as the surrogate. And then the embryologist gives me the catheter with the embryo in it. And under ultrasound guidance, where we have a little ultrasound probe on the bladder, and to visualize the uterus, I put the embryo in through the cervix into the uterus. None of it should hurt. I mean, the most uncomfortable part is probably the speculum, which nobody likes, as well as having the full bladder. But the whole thing lasts a couple of minutes. That's it.
Okay. And typically, are the surrogates allowed to bring somebody in the room with them? Can they have a companion or the parent there?
Yeah, I often see, and it's actually a really nice sort of sisterhood. I often see, like, if two surrogates are friends and they're there on the same day doing embryo transfers for different doctors, or even the same doctor, they'll buddy up and come in and, hold each other's hand, which is really nice. We have nothing against that. In fact, I think it's a really nice thing. Sometimes the intended parents, if they're close by, or sometimes even if they're not close by, this is a big moment in their life, they'll come for the embryo transfer in there as well. Sometimes it's a little bit of a party. We have myself, we have the nurse, we have the intended parents, and we have the surrogate's partner or the surrogate's friend, but it's all okay. It's fine.
It definitely sounds like a good party to be at. Okay, great. So after the procedure, what typically happens and what can she do to maximize success of the embryo transfer?
Yeah. Surrogates are so incredibly giving in this process. And I just love how they just really want to do everything they can to make sure that pregnancy works out. So it's like that part always, never ceases to amaze me. But, once you've made it to this process, like you're a good candidate to get pregnant. Like we've chosen you because you're good at this. So I always tell surrogates, like, don't stress out. Like I tell all my patients, you did everything you could. This was the easy part. Certainly we say, pretend you're pregnant after the embryo transfer has occurred, practice a good, healthy lifestyle. You don't have to lay in bed for 14 days until the pregnancy test happens. Resume normal activities within reason, of course. Eat healthy, take your prenatal vitamins, absolutely stay on the medication. I think I can't stress that enough. I think that's the big difference with surrogacy cycles as opposed to your own natural pregnancy. You have to remember to take those medications, the estrogen and the progesterone. Particularly the progesterone is really important because when you're not getting pregnant naturally, you're not making any of those hormones. So those hormones are vital for implantation. So stay on all the medication and, just be healthy. Avoid any toxic habits, no smoking, no hot tubs. But other than that, do what you're used to doing.
So otherwise, other than the medications, how might this pregnancy be different from her previous natural pregnancies? Does she feel any different?
Yeah, I think a lot of it is attributable to the medications, and that's probably why many surrogates prefer natural frozen embryo transfers because it's less medication. The medication does, it is fairly strong medication, and sometimes surrogates will feel, more bloating or breast tenderness or nausea or headaches because of the estrogen and progesterone. I can certainly tell you all my infertility patients as well as surrogates sort of like do a little jig for joy at that 12 weeks when they get to stop the medications. So that certainly creates some changes in the first 12 weeks that might be different from regular pregnancy. Otherwise, typically we're only putting one embryo at a time. So it's a single embryo transfer and hopefully a singleton pregnancy. But occasionally if an embryo splits or you put in two embryos and you have twins, obviously that makes it a different pregnancy. Sometimes surrogates will have a little bit more nausea and maybe vomiting of pregnancy or hyperemesis just because it's not just pregnancy, but it's compounded by the hormones that you're on. So sometimes surrogacy pregnancies with the hormones will feel a little bit more symptomatic in early pregnancy. Occasionally surrogates will be on additional medications from the estrogen and progesterone like aspirin and Fragmin, depending on what their clinical scenario is. So sometimes experiencing spotting in the first trimester, they might say, wow, I never had this in my natural pregnancies, but I'm having a little bit of spotting and bleeding in my frozen embryo transfer pregnancy. That's not uncommon with IVF pregnancies. It is known to happen more with IVF pregnancies. And B, often we'll put surrogates on baby aspirin because they're on hormones, and that can sometimes cause a little bit of bleeding. But generally speaking, 99% of the time, everything's fine and there's nothing to worry about. We will sometimes diagnose subchorionic hematomas. That's a little bit of blood around the sac that, again, is much more common with IVF pregnancies as opposed to natural pregnancies, and certainly more common if you're on any of these blood thinners like aspirin and Fragmin. So sometimes we'll ask surrogates to be on what we call modified bed rest, which is like less activity and pelvic rest. So sometimes that's something that's different from typical pregnancies. But of course, we understand many surrogates have, active lives and kids to take care of their own. So sometimes it's not feasible to be on complete bed rest. So, if you have any questions, we always tell surrogates, speak to your doctor, tell them about your scenario and they'll be able to guide you.
Okay. Now so can you go over this prenatal screening, like the pregnancy testing and then prenatal screening after the embryo transfer, what that
Yes, for sure.
Like?
So with all luck, pregnancy results from a frozen embryo transfer, and 12 to 14 days after the embryo transfer, you do a blood test and it's positive. So because these are obviously very valuable pregnancies to the intended parent. And because we kind of put the embryo into the uterus, we always want to watch that pregnancy test more closely. So whereas in a natural pregnancy, you might have done one blood test and then you have your ultrasound, we probably will do at least 2 pregnancy tests to make sure the numbers are going up appropriately. Typically, we look for an almost doubling over 2 to 3 days. So if the numbers are doubling well after 2 or 3 HCG hormone levels, then and all goes well, then we'll book an ultrasound at 6 weeks, whether that be locally where the surrogate is or coming into our clinic. We'll do a 6-week ultrasound for a viability check. So we want to make sure that there's indeed one pregnancy, that it's viable, there's a good fetal heartbeat. So that's the check that happens at 6 weeks. After that, if all looks well, then we'll space the next ultrasound out by a few weeks because there's no need unless there's been a history of miscarriages or the intended parents want. There's no need, absolute need to bring a surrogate in every week for an ultrasound. So usually a couple of weeks later, we'll do another ultrasound. Even if a set of intended parents and surrogate couple, even if they've done genetic testing of the embryos, we do recommend a blood test at 10 weeks called the NIPT. That's part of the prenatal screen. What that does is it kind of double checks the genetic testing, and it's based on fetal DNA in the surrogate's blood. It's just a simple blood draw. It's nothing invasive. They come in for a 10-week ultrasound to make sure the baby looks good and has a good heartbeat. Then we do this blood test, send it off to the lab, and it gives us the chromosome structure of the pregnancy to make sure there's no Down syndrome, and it can even give us the gender. And it looks for something called microdeletions, which are another common genetic abnormality. So typically we do that at 10 weeks, and then we bring the surrogate in at between 12 and 13 weeks to do the routine screening test for Down syndrome called the nuchal translucency. That's also an ultrasound and blood work that can happen at our clinic or through their obstetrician or midwife. And that's just conventional screening for Down syndrome. And then after that, they go off to their obstetrician. Now, if any of these things, God forbid, comes out abnormal, then we'll refer to a specialist to consider more invasive testing, which is a CVS or an amnio, where a needle has to actually go into the uterus to withdraw fetal cells. Fortunately, this is an incredibly rare occurrence because most intended parents are doing genetic testing prior to frozen embryo transfer. So we kind of already know it's a genetically normal embryo.
Okay. So it seems to me like the biggest difference, I guess, from a natural pregnancy or what the surrogates would have experienced in their own pregnancies is just there seems to be a lot more testing, a lot more frequent ultrasounds and visits to the physician to make sure that everything is going well.
Yes, yes. And a lot of that is mostly for reassurance, and the intended parents like to know that every week things are going well. So I mean, it's not an absolute, like we've had surrogates that do an ultrasound at 6 weeks, sometimes 10 weeks and 12 weeks. So it doesn't have to be that frequent, but it's nice for both the surrogate and the intended parent to see that things are going well.
And can we look at the subchorionic hematoma?
My favorite topic.
Again, I know you went over it a little bit already.
Yeah.
It seems to be, like you said, more common in IVF pregnancies. It is
Absolutely.
really scary for a lot of people.
Yeah.
Why is it more common with IVF pregnancies?
Yeah, it's a good question. And I agree with you. It is a very scary thing, both for intended parents and surrogates, because, you want this pregnancy to be perfect, and saying the word blood around the pregnancy is scary because everyone thinks, does this mean I'm going to have a miscarriage? Well, let me reassure everybody in the audience and, on this webinar by saying that most, if not all, subchorionics do not lead to a miscarriage. So as common as it is that we see it, I've rarely, if almost never, seen a miscarriage result from a subchorionic hematoma. That being said, vaginal bleeding is common with subchorionic hematomas. So every time a surrogate sees bleeding, she worries she's going to miscarry, and obviously so does the intended parent. You asked why they're more common in IVF pregnancies. Inherently, IVF pregnancies have different placentation and different blood structure formation from when the embryo is invading to create the placenta. That's just sort of part and parcel for the fact that these embryos were created in the IVF lab, and there's just something different about vascularity of an IVF pregnancy. On top of that, as I said, most of our surrogates who are on hormones are on baby aspirin to protect them against having any blood clots. So if you pair up an IVF pregnancy plus being on aspirin, which can cause a little bit of bleeding, it's not uncommon to see these small subchorionic hematomas or see a little bit of bleeding in the first trimester. So a certain population of surrogates, if they've failed a few transfers, will put on an even stronger blood thinner fragment, and that also engenders these subchorionic hematomas and bleeding. But that's why we often will follow surrogates who have a subchorionic hematoma more closely for reassurance that it's not getting bigger, it's getting smaller, that they're not having any more bleeding, and we'll often stop the blood thinners if need be, if the subchorionic hematoma is enlarging or if they're having significant bleeding. The idea of putting surrogates on bed rest or modified bed rest is just that the more activity you have, the more you might see bleeding, and that engenders anxiety both on the side of the intended parents and the surrogate, and run back to the clinic. They have an ultrasound, and that can create more bleeding. So we just like everybody to rest so that the bleeding tendencies are less and nobody gets worried. The only thing I should also mention, just since we're on the topic of subchorionic hematomas and bleeding, is I think it's important for all surrogates to know their blood type, because if their blood type is negative and there's a possibility that the blood type of either the egg donor or the intended parents, the mother's eggs, or the father's blood type is positive, then the surrogate needs a shot of something called ROGAM if they have any bleeding in pregnancy. So I think it's important that they know that.
Okay. Yeah. All right. So I guess that kind of covers the first trimester.
Yeah.
What happens next, Dr. Sharma? And again, how is it going to be different from an actual surrogate's own pregnancy?
Yeah. So after 12 weeks, once a surrogate stops the additional hormones, the estrase and or the progesterone, depending on what kind of cycle she did, the rest of the pregnancy overall is conventionally like a natural pregnancy in that they do their 20-week anatomy scan to check the anatomy of the baby. They do a sugar test around 25 weeks where they drink a sugar drink to rule out gestational diabetes. Sometimes they'll have ultrasounds to check the baby's weight in the third trimester. Overall, it's from that point on, it's a pretty normal pregnancy. Again, the only difference would be maybe monitoring because the intended parents, want more frequent visits or more frequent ultrasounds. But there's in the second and third trimester, unless any complications develop, it's quite typically a routine pregnancy. Probably any other differences that would arise would be at the time of delivery, in that you would have your intended parents potentially there for the birth of the child, and there would be paperwork with regards to paternity and whatnot. I think, I'm not part of the delivery piece because we usually end our relationship is as fertility doctors at 12 weeks and the obstetrician or the midwife takes over. But I imagine some intended parents want the surrogate to breastfeed, some intended parents don't. So that's usually something that's talked about with the intended parents, as they make a birth plan.
Okay, wonderful. Well, that brings us, full circle on the whole pregnancy, Dr. Sharma. Is there anything else that you would like to add or talk about with regards to the medical process and potentially something for surrogates to think about if they are considering this journey?
Yeah, I think that if you're thinking about being a surrogate, first of all, it's a great experience, and I think it's a great gift to give our patients. There's lots and lots of patients who need surrogates, and sometimes it's not easy to find a surrogate that A, you can have a good match with in terms of your personality, and B, that's going to be a fitting surrogate from the medical standpoint. So I would just say it's important to be in the best of health possible. So if you're thinking about it being a surrogate and you have, any minor or even moderate medical issues, it would be good to see your family doctor or obstetrician and sort of make sure that those are under control before sort of applying into the surrogacy process. probably a good idea if you're thinking about being a surrogate, and lots of young women don't see their family doctor on a yearly basis because they're healthy. It's probably a good idea maybe to touch base with your family doctor and just say, you know, can you sort of do a whole check to make sure that I'm in, you know, good condition for being a surrogate? Because that'll actually maybe decrease your time and get you to getting to a transfer sooner once you actually start the medical process, if you're sort of given the clean bill of health. So that would be a good thing. If there's any medications that you're on, maybe same thing, discussing them with your family doctor, and, you know, if you could potentially get off of them and if they're safe in pregnancy. Maintain a healthy body weight, start taking prenatal vitamins. We do say that surrogates have to have been at least 3 to 4 months after a vaginal delivery to get pregnant again, and typically 6 months after a C-section. So if you've just delivered, you want to be 6 months out from a C-section and at least a couple months out from a vaginal delivery, and you cannot be breastfeeding.
Okay. And what is the reason for those two things?
So in terms of a vaginal delivery, it usually takes about 12 weeks for the uterus to get back down to normal size. So you want the uterus to be back to normal before you implant an embryo. Oftentimes surrogates will still do their screening maybe 2 months after a delivery, and then they just won't do a transfer for 3 months. Typically, we don't see it as much with a vaginal delivery because you need a little time to heal. But for a C-section, sometimes they'll come see us like 4 months after a C-section. We'll say, well, let's wait a couple months before we actually do the C-section. With regards to the breastfeeding piece, again, you can typically do your screening while you're breastfeeding. But the reason we don't want you to be breastfeeding like your own child when you're doing a frozen embryo transfer is A, the hormonal medication can pass through the breast milk to your baby. And B, the episodic increases in the hormone that is responsible for milk secretion in the breast, prolactin. Episodic secretions of prolactin can inhibit implantation. So we don't want those hormone fluctuations to mess around with the hormones that we're giving for a frozen embryo transfer.
Okay, good to know, good to know. Okay, well, okay, so anyone who's watching us live, if you have any last minute questions, please send them in now. And also, I'll be staying in touch with Dr. Sharma, so if you want to DM us with a question, I'd be happy to send it to her, and we can post it on our Facebook and Instagram pages. That's okay with you, Dr. Sharma?
Absolutely. I'm always happy to answer any questions for any potential surrogates or egg donors for that matter. We're here to help you. You know, we want you to work with us. So yeah, we're always happy to help.
Okay, awesome. So please check out Dr. Sharma at the Conception Diaries and at Create Fertility Center.
Yes.
And again, if you have any questions that you'd like to send in, you can also send them through the Extraordinary Conceptions pages, or you can send us an email. But yeah, thank you so much, Dr. Sharma, for joining us this evening. Once again, you've been so helpful in answering all of our questions.
Oh, thanks so much, Petra. It's so great to be here, and it's great to be able to give some valuable information to potential surrogates who are really helping our patients. So thanks for having me.
Awesome. Thank you.
Okay,
right,
take
well,
care. Have a safe and quiet night.
Have a great evening, Dr. Sharma, and everybody stay healthy. Keep your social isolation going.
Yes, we didn't touch upon COVID, but we've done a webinar on that as well.
Yes, so please check out our Instagram TV and our Facebook pages for the COVID if you want to if you want to learn more about COVID and how that affects your surrogacy journey as well as your fertility journey. All right, well, let's signing out. So thanks again, everybody, for joining us, and I hope you have a great evening.
Take care.